So hi, my name is Nadia Harbeck. I head the breast center at the University of Munich in Germany, and we're meeting here at the San Antonio Breast Cancer Conference to discuss on one of the major improvements in oncological care of breast cancer patients, which is the CDK4/6 inhibitors. I'm joined here by three distinguished colleagues, one from Europe, two from the US. Why don't you introduce yourselves?
Hi, I'm Mark Beresford. I'm an oncologist from the UK, from Bath, and I'm co-chair of the UK Breast Cancer Group.
Hi, I'm Sara Hurvitz. I'm from the University of California, Los Angeles. I'm a breast oncologist.
I'm Shom Goel. I'm a physician scientist at the Dana-Farber Cancer Institute in Boston.
So let's start talking about what we saw in 2017, because I think we've seen quite a lot of data, and all of us were involved in one trial or the other. So Mark, why don't you start? What were the most impressive data for you?
So I think it's really a follow-up from some of the data that we saw the previous year, really, in terms of first-line metastatic usage. So this is looking at the use of the CDK4/6 inhibitors in patients who haven't previously been exposed to endocrine treatment. And we're seeing some sort of more updated analysis of those, and it's really pretty comparable between the drugs in terms of the benefits. We're looking at sort of 8 to 10 months of progression-free survival benefit first line. So I think that's really been solidified this year, and it's impacted on what we can do in practice in terms of availability of the drugs, certainly in the UK, and it's going to really change how we treat people in the first line setting.
Are there any trial data you particularly enjoyed seeing, or do you think they all sort of show the similar picture?
I think for me, between the drugs, there's nothing to choose at the moment, which is kind of reassuring, and I think that's been reflected on the decisions that have been made in terms of commissioning of the drugs so far, yeah.
Sara, you've been involved not just in the metastatic breast cancer trials, but also using some of these drugs earlier in the setting. What's your takeaway?
Yeah, so I was involved in the neoMONARCH study, which looked at neoadjuvant use of abemaciclib. And in this study, we had 3 arms. The first 2 weeks, patients received either abemaciclib or anastrozole or the combination. And then after 2 weeks, after having a second biopsy, received both drugs until the time of surgery. So the final data are being presented, the final clinical data, and we are showing that the Ki-67 reduction is substantial in over 90% of patients who receive abemaciclib-based therapy in the first 2 weeks, compared to anastrozole, where it's just significantly lower. And the complete cell cycle arrest is also quite low. And now we're seeing data emerge from prospectively run studies like POETIC that show a Ki-67 change from baseline to 2 weeks does appear to be predictive of long-term event-free survival or disease-free survival. So we might see now more of these exciting agents be evaluated in the neoadjuvant setting, which allows us to run smaller clinical trials, test hypotheses, get sort of signal-finding studies done with fewer patients in a shorter period of time. So I think that's an exciting thing, not just for CDK4/6 inhibitors, but for new therapies that are in development. Mm-hmm. And then there was the premenopausal data that I think we need to discuss, because this was a big splash. Nadia, you were a part of that study.
Yeah, it was a great pleasure to be part of the steering committee and also actively recruit patients. The MONALEESA-7 study is still so far the largest study, I think, in premenopausal patients. We've seen some data from the PALOMA-3 study, which had about 20% premenopausal, and MONALEESA now in MONALEESA-7 in the early phase, the first line setting, also recruited these premenopausal patients, and there's quite a substantial number was actually younger than 40 and even younger than 35, so there will be a lot of science we can still dig in with regard to tolerability and also aggressiveness of the cancers. But I think the major findings were that there was a substantial prolongation in progression-free survival with a hazard ratio similar, if not even a little bit lower than we saw in the postmenopausal women. So I don't know what you think of the data, but I thought it was great data. And if I recall my own patients, they did so extremely well. And a lot of physicians have the feeling that in younger patients you need to resort to chemotherapy earlier. I cannot confirm this from this trial.
I agree. I thought it was phenomenal data. We haven't seen such a large study in over 15 years that's just focused on premenopausal younger women. What I also thought was interesting is that they used both tamoxifen or an aromatase inhibitor, so they didn't require that patients receive an AI, and the outcomes look very similar for the two groups. And all patients, of course, got the LHRH analog.
Yeah. So I think we will still need some time to digest that data and wait for the full publication, and then I think this will definitely change the landscape on how we treat these young women with metastatic hormone receptor positive, HER2 negative breast cancer. But we have one colleague here who not just treats patients clinically, also knows a lot about the translational aspects, because you do a lot of translational work. Do you have an idea, are these three CDK4/6 inhibitors actually different from each other? What does the preclinical data show us?
Thank you, Nadia. Yeah, that's a fascinating question. I mean, I think, firstly, I just agree with everything that Mark and Sarah have said. This is a very exciting time to be working in this field. And for those of us who are involved with this class of agents, it's impressive how rapidly new data and positive data just keeps coming at us. And I agree, now that we have the drugs available, at least in the US, all three CDK4/6 inhibitors are approved. The next question that we start to ask ourselves is, well, how can we best use these drugs? And one question that comes to mind is, are they the same? And I think I would agree with Mark's point that at present, based on the data that we have from the first-line randomized studies, the drugs seem to be equally effective, at least in the setting of ER-positive breast cancer when given in conjunction with hormonal therapy. There are some important differences, however. It's notable that abemaciclib has a different chemical structure to that of palbociclib and ribociclib. Those two are actually quite similar. And that seems to be accompanied by some unique properties that we see with abemaciclib. It has a somewhat different toxicity profile. We tend to see less neutropenia with that drug, but more diarrhea. And interestingly, and I think at the moment something that still remains unexplained, it does have a higher response rate when used as a monotherapy. And in fact, last year we heard the results of the so-called MONARCH 1 study, which in the US have actually led to the approval of abemaciclib being used as a single agent as well. Now, at a preclinical level, you might ask, why is that? What is it about abemaciclib that's different? Does it inhibit other things than CDK4 and CDK6? And I think there's a lot of debate in the field right now on that question. At present, I don't think we know the answer, especially when it comes to the effects of these drugs in patients.
So you say there may be some clinical differences on the long run, but so far the side effects differ a little, but you couldn't say that there is one drug that's more effective than the other.
That's right. And I think, you know, at this meeting we learned some very interesting information. There was a very nice study which took my interest, presented by some scientists at the Harvard Medical School, who really did a very comprehensive study comparing the three different CDK4/6 inhibitors in the lab. This is not in patients, this is in the lab. And they did find some specific qualities about abemaciclib, that at times it was actually able to kill breast cancer cells in a dish, which the other two drugs were not. How that manifests itself in our patients, I think I'd agree with you. Maybe we'll work that out with a lot more time and study.
Yeah, I think we all need more experience. When I look at the situation in Germany, we have abema not approved, we have ribociclib and palbociclib approved. Palbociclib, obviously, we have longer experience. It has quite a broad European approval, also with regard to the combination partner. The questions my colleagues always ask when to use it. Do we use these substances first line because we do the best things first, or do we use them second line because we want to see how endocrine monotherapy works? So that's a big debate. So Mark, how is it in the UK?
I think that's the important question now. So we've very just recently in the UK had approved ribociclib and palbociclib first line, which is great. We've got the option for both. And the real question now is there anybody who doesn't get these drugs? I think that's, rather than looking at who should, it's who shouldn't. And it's hard to find from the trials a group that doesn't benefit. You know, we've said that the premenopausal benefit, postmenopausal, elderly, node positive, node, you know, all different grades of disease and all kinds of things, and not really dependent on the site of metastases, whether it's bone or visceral. So it's hard to find a group that don't, but it does feel a little bit like overtreatment in a certain section of the population. Some elderly women who may do very well just on hormone treatment alone, and then we're confining them to the hospital every month with lots of blood tests and follow-up appointments, potential toxicities. So I think there is probably still a group who wouldn't need to start with these drugs. We do know they work well in the second-line setting, and we have data there to show that with fulvestrant it doubles up the progression-free survival at that point. So you could argue that you're getting your benefit later on. Whether the two things quite summate is difficult to know. But we don't yet have approval in the second line, so it's certainly in the UK we're in a position where if we don't use it first line we can't use it, so, which is a shame, because I think there may be a group of patients who we could treat with hormone therapy first and then add in later on.
You know, I think there's an important point to be made as well. I agree that there are some patients, bone-only metastases, very long relapse-free interval, who may not benefit. But looking on the other hand, I see a lot of patients who come to me from the community because their physicians have recommended first-line chemotherapy with a taxane because they have liver metastases or lung metastases and are mildly symptomatic. And I would argue, now we don't have time to relapse data yet from these studies, but you see very early responses with the use of CDK4/6 inhibitor therapy, and we're looking at response rates in excess of 40, 50, even 60% in patients with visceral metastases. So my argument would be we should not be knee-jerking to chemotherapy, which I know we have guidelines telling us to treat with hormonally directed therapy, but a lot of oncologists overdiagnose visceral crisis and run to chemotherapy first, and I really think we should be using this doublet type of therapy in those patients.
Yeah.
I would tend to agree, and I think we saw data earlier this year from the Paloma-1 study, which was a randomized phase 2 study using palbociclib, that in fact the use of a CDK4/6 inhibitor can delay the time until patients need to begin chemotherapy, and I think we should not underestimate how important that is to our patients. If I could just for a moment, going to Mark's point about do all patients need these drugs, I think at the moment there's still a big question mark there, as Mark said. But it's worth noting that there are a lot of efforts going on at the moment to try and answer this question. So here at this meeting, we saw a combined analysis of 2 of the abemaciclib studies, the MONARCH 2 study, which was the second-line study, and the MONARCH 3 study, which was the first-line study, trying to address the question, are there specific clinical subgroups of patients that derive particular benefit from the use of a CDK4/6 inhibitor? And there was a suggestion, and it's only a suggestion, that certain clinical subgroups may derive more or less benefit from abemaciclib. In addition, some of the more translational studies being presented at this meeting are starting to look at whether changes in the tumor tissue itself, whether it's the activity of different genes or the presence of different mutations, may predict who does and who doesn't need these drugs. We don't have anything definitive there yet, but I think in the next 1 or 2 years, we may learn a lot more.
So if I pick your translational brain for one more time, are there any biomarkers right now?
You know, it's very interesting. I mean, if you want an honest answer, I don't think we really have a good biomarker right now. Of course, the drugs are used at present to treat patients with estrogen receptor positive, HER2 negative breast cancer, so that is, in a sense, a biomarker. But beyond that, I don't think there are any molecular markers that you could use to pick who does or doesn't need a CDK4/6 inhibitor.
I want to be a bit provocative. If you mentioned the pooled analysis of the MONARCH studies, I think we should be very careful with the subgroups there because they have the shortest follow-up time of all the studies. If you look at the Paloma data, also the Mona Lisa data, some things don't pan out the same way. And in particular, the subgroups where you say, well, with a short disease-free interval, they may benefit more, but those with the longer disease-free interval may not benefit. I think this is a bit biased by the fact that the follow-up is short and the aggressive tumors have more relapses at the time. So I personally would be very careful with giving clinical subgroups, and I would more agree with Mark that they're actually, I mean, you could think of clinical subgroups, but they're not substantiated by the data at the moment. So in a country where I have the choice, like unlike the UK, I would always go for the best therapy first, unless I have a woman who says that they do not want to come in, which is very rare. If you explain to the patients the benefits of having this prolongation, which is substantial in progression-free survival, I have yet to see the patient that says, I don't want to come in for the blood count. So, and also we lose patients. There's very good data that with every line in the metastatic setting, you lose about 10 to 20% of your patients because they just can't go on, don't want to, or the disease is progressing so fast. So I'm a big believer in the first line use. I don't know, Sara, you also have the choice in the US.
Yeah, I agree. I think that the progression-free survival benefits we are seeing have not been reported with endocrine therapy or chemotherapy in the frontline setting. We're at 2 years now, and that's historical. We don't have survival data, so that's the other side of the coin. But I will be shocked if in the long run we don't see survival data. I think the fact that we have a little bit of competition between the agents is going to serve our patients well, because there are efforts, at least in the US, to have blood draws done at home, EKGs to be done at home. So there are resources that are being allocated to our patients to make it easier for them to be on these therapies.
In Germany, a big decision when we went to the HTA assessment was that progression-free survival may not be such a meaningful endpoint from a patient point of view, and there is no improvement in quality of life, at least in the first-line setting. And they also thought that the side effects were quite substantial with the neutropenias. So if you do a lot of management, I understand, in the first-line setting, do you have any issues with the side effect management or the screening procedures recommended for these drugs?
Yeah, that's a really interesting question, because as Shom said, they are subtly different in their side effects. And the neutropenia is common. It's about 60 to 65% of patients get neutropenia, but very rarely associated with sepsis. It's only 1 or 2% of neutropenic sepsis rates. So it's not a big issue clinically. It's something that needs watching and managing, but dose adjustments and dose holidays can cope with that. I think with the abemaciclib, the concern is the diarrhea, and that may be more impactful on patients than a blood test result, which they don't see any symptoms from. But practically, of course, with ribociclib, you need to do the ECG monitoring. That makes things a little bit more tricky, particularly if patients live a long way away. So there may be a little push, certainly in the UK, to use more palbo. It's very dependent on what you're used to and what you've been using, I think.
Sara, you're the one, I think, among us who has the experience with women who have not had any other pre-treatment in the early stage setting with the neoMONARCH. How is the tolerability in women without any cancer pre-treatment?
So neoMONARCH was designed with primary prophylaxis with Imodium. And it was an overshot. We were making our patients quite constipated by using upfront use of Imodium. So I think the aggressive use of Imodium, it's not like neratinib where we really need to be pre-treating patients, but patients do need to go home with a prescription or a bottle of Imodium with careful instructions in terms of when to call, when to take it, and how to moderate. Now the patients I had on abemaciclib in the neoMONARCH, there were GI side effects. The tummy rumbled, there's a little nausea, GERD. Even though the diarrhea could be controlled, they were aware they were on this medication, but it was tolerable. I didn't have any patients come off of therapy early for this.
So you think if you're looking at the adjuvant trials that are going on, you think the toxicities will be manageable?
I think they're definitely going to be manageable. There's a learning curve there in terms of how to best manage it.
So that was already a little bit of a look into the future with the adjuvant trials, because for all three CDK4/6 inhibitors, there are now adjuvant trials ongoing in some parts of the world, maybe have not started in other parts of the world. Is there any other data you would like to see in the next 1 or 2 years which you think you need in order to sort of manage your patients better with CDK4/6 inhibitors? Why don't we start here again?
I'm keen to see how the HER2 positive patients would respond. We do have some posters at the meeting which are starting to just report on that, and there's a group with brain metastases who seemingly didn't respond very well to the combination with abemaciclib. But it's very early data, small patient populations, and I think we don't know what's happening viscerally as well. So there may be a role for these drugs in HER2 positive disease.
I'm really excited to see biomarker data come out. We really need to encourage our patients who are going on these studies to sign the optional consent to have a tumor biopsy taken at the time of progression. I, like Shom, am very interested in markers of resistance, cyclin E amplification, CDK2, phospho-RB, loss of RB, et cetera, and how that plays into the development of resistance I'm also interested in hearing more about CDK2/4/6 inhibitors. Historically, they've been quite nonspecific and toxic, but there are a couple that are being developed now that might help circumvent these areas of resistance if they're tolerable. That's a big if.
Like Mark and Sarah, I'm interested in seeing a lot more translational work being done over the next 1 or 2 years so we can optimize the way we use these drugs. I think the HER2 positive issue is important. I think it's worth mentioning that there may actually be, we don't know yet, even a subset of triple negative breast cancer patients who could derive some benefit from these drugs. Certainly laboratory studies suggest that, and there are some posters at the meeting discussing ongoing trials that are designed to specifically ask that question. And then I think the next wave of information that I'm looking for is what else can we combine a CDK4/6 inhibitor with apart from hormonal therapy? Or are there triplets? Are there additional agents we can add in addition to hormonal therapy that could improve the efficacy of these drugs? And a lot of the preclinical investigators at this meeting are presenting some very encouraging preliminary data on various combinations.
So there's going to be great data to be expected for the next year or two. From my point of view, I think I'm excited about the adjuvant trials. I think it's very important that we get these drugs into the early breast cancer setting. I'm still a bit worried about that we may not define the patient population properly. We saw, like you mentioned, data from the POETIC trial seeing that the Ki-67 is actually a very good indicator of who is going to be endocrine resistant and may need an add-on. We presented from our own ADAPT study data at ESMO showing that patients with a Ki-67 of 40 and more at baseline had a 5-year outcome despite state-of-the-art chemotherapy that was worse than the triple-negative population. So I think we're underestimating the risk in the luminal B population. That's why I'm excited about the adjuvant trials. So I think that was a great discussion, and my take-home message is that CDK4/6 inhibitors are exciting medications, and we're all glad we have them. We like to use them rather earlier than later, and I think there was quite a good consensus about how to use them and the management across the Atlantic, if I take it. So I would like to thank you all very much for discussing this with me, and thank you all for joining us and watching this podcast.